Otherwise, we'll have more time to talk about TB and HIV, which is the expertise that we have at this point in time. But that said, we'll give it a minute. We are all time bound. And since the room has already been scheduled beyond the 45 minutes that we have, we're going to have to start on time. Right. Are we live? We're now live. It's 10:45, and this is a session on the triple burden of diseases: HIV, TB, and hepatitis. We clearly know that these coexist very often, and that they actually interact in a very complex way to affect public health systems. And that these three diseases in that intersection exacerbate each other, leading to certainly increased morbidities and mortalities. HIV, we know, weakens the immunity, making individuals very susceptible to different opportunistic infections, which include TB and the hepatitis. And co-infection with HIV can also accelerate hepatitis B and C. TB, on the other hand, we know is actually the highest mortality in patients who have got HIV, especially in all people who also have weakened immune systems. Viral hepatitis can lead to liver damage and increase the risk of developing liver cancer. And co-infection with HIV complicates the management of the viral hepatitis. We were going to have the three speakers. We just have Nigel Garrett, who is Professor Nigel Garrett, who is head of HIV pathogenesis and vaccine research, an associate professor in public health at CAPRISA, the Center for the AIDS Program of Research in South Africa at the University of KwaZulu-Natal. As I said, Nigel's expertise are largely on HIV. We were going to have him talk largely on some of the innovative treatments that are available at the moment for HIV, including prevention. And with his expertise, I'm sure without the other two speakers, we can extend the session a bit and give him an extra 5 minutes, mainly talking to HIV, as I said. It would be unfortunate if at all we don't have the other speakers join in as we go along. In the meantime, I'm going to call upon Nigel to give us his presentation. Thank you. Shall we welcome Nigel, please? Thank you.
Thank you, Joe. Thanks for that kind introduction, and thanks to the organizers for inviting me to speak here in Zimbabwe. It's the first time for me in Harare. We've come out of a 3-year COVID battle, and I don't know how you feel, but I feel I'm kind of catching up with HIV research. And it's been a real pleasure just thinking about some of the innovations that we've been through and that we now rapidly need to implement in the HIV space. So I prepared this. I've got slightly too many slides, so I'm lucky that maybe I have a little bit more time. I just wanted to start very briefly with a little bit of epidemiology. So we know from the data that the number of new infections, so HIV incidence, is coming down, but not really fast enough to reach the 2025 targets. And you can see in that little blue dot, this is where we should be. So in 2022, we still had 1.3 million new infections. So this is really what we're trying to achieve with HIV prevention innovations to reduce incidence. And then AIDS-related deaths are declining, and we're kind of within reach of that. But I think, Joe, that's obviously where TB remains the #1 killer amongst people living with HIV. So this just really shows, this has been bugging me a little bit. Are there any specific subgroups we should be now targeting much better now that we've reached 90-90-90 in a lot of settings? And it really transpires that there isn't really a silver bullet to target any niche populations for HIV prevention. We do need strategies that cover broad populations for HIV prevention. Having said that, we do consistently see these predictors of HIV incidence, and one is obviously the non-cohabitating with primary partners. The young age keeps coming back to us. Curable STIs, and we have a long way to go on the STI prevention field with new vaccines coming along. HSV2 is also consistently a risk factor, and then obviously multiple partners. But only there's very low ability to differentiate these populations subsequently in terms of who then acquires HIV. So here you can just see in that graph that 40 to 65% of the population are essentially categorized at what we call now medium or moderate risk. And we would need to identify about 75% of HIV infections that way. So if you look at individual risk behavior, it really adds minimal predictive ability versus only looking at geography and age. So I always say young age is your main risk factor in our setting, especially in sub-Saharan Africa. And then that's really why we need this toolbox. And this is one of Linda Gale Becker's cartoon she likes showing, but it really shows that we have many tools now. We really need to focus on implementing them in an integrated fashion. This is just not to forget about the key populations. We know that they play a big role in terms of infections, so in terms of HIV incidence, but also preferentially need treatment. So often don't do as well in the HIV care cascade, many remaining viremic. So better services for female sex workers, for men who have sex with men, for people who inject drugs, and also transgender communities are vital to reduce the HIV burden. So here's an overview. I hope you can see that from the back of the current HIV prevention research and implementation tools we have. You all know about the dapivirine ring that was well evaluated and it showed moderate efficacy. We are kind of working out ways of implementing it despite the slightly less efficacious product. The long-acting injectables, I think you've heard a lot about at the conference. Obviously, cabotegravir is a big one, not just in the science space now, but in the policy space and the activist space. We do need to find ways of rolling out this at a large scale. We have a product that's 80% effective. It's got to be rolled out, and it's got to be available to people who need it most. And then we have lenacapavir studies. We'll go through that a little bit more in detail. And oral PrEP studies. So there's a Merck product now that's a once a month pill. So that may also become an interesting product to use for people who may not like injectables. And then obviously making it a lot simpler for young women, particularly with the dual products with contraceptives and ART. This is just the cabotegravir graph. I think it just shows you the efficacy of, in this case, it was 89% in preventing HIV infections. It's an interesting product. It's been rolled out now in the US, and it's been rolled out for treatment in the US as well, in other countries. So the key here is, for me, if you look at the modeling, that it would increase PrEP use because a large majority of additional people would want the injectable over the oral tablet. It was reduce HIV incidence by 29%, and you need to see that at a population level. So that would be a huge impact. It could reduce up to 4,500 AIDS deaths. That's kind of a medium. There's obviously a range around that. And then, yeah, critical to really roll it out. The one thing to remember, it could increase INSTI resistance. You know, we're using dolutegravir-based treatment now. So we need to always keep an eye on the resistance to our PrEP products and make sure that that doesn't interfere with our treatment regimens. Sorry. So the next one is really the lenacapavir, and everyone's really excited about this. This is a trial run by Gilead. It's in many of your clinics. I think many of you probably are involved in these studies. It's a 6-monthly injectable. It's administered subcutaneously. So there is a possibility of self-administration potentially in the future. It's got a high resistance barrier, which is always important. It's got a novel mechanism of action, so that is also good because it doesn't compete with other drugs in terms of resistance. What to pair it with for treatment? So the issue here is if you have a 6-monthly injectable, if you want treatment with another product, what do you use? Daily Truvada or, 2-monthly cabotegravir? So you need to find a product that marries with it, and maybe the monthly pill could be potentially an additional factor for treatment. So excellent for prevention, but a single agent just for now. And the 2 studies that are ongoing is a Purpose 1 study in the adolescent girls and young women. And then obviously there's a second one among the cisgender men, the transgender women, and also men who have sex with men. So we are quite eagerly waiting. I think the DSMBs are happening. So if this is an effective product, it could be potentially be big news soon. Then we have this question, which Joe raised earlier. So some people ask me, so you're doing vaccine research in HIV. Why do we still need to work on BNAPs? And many of you were probably part of the AMP study. I hope most in the room have heard of the AMP study, where we tested with the HVTN a broadly neutralizing antibody for HIV prevention. And what you can see in this table, this figure here on the right, is the blue line shows you prevention efficacy. So if you looked at virus that was transmitted, that was sensitive to the antibody, and the antibody was called VRC01, then the antibody protected you by 75%. Okay? The problem in the study is that a lot of viruses were not sensitive to the antibody. So you got a lot of transmission still. So overall, the study didn't show an effect. But if you did the sub-analysis, you saw that actually it does protect from certain viruses. Okay? So this is why we say this was a proof of concept that broadly neutralizing antibodies can prevent HIV infections. Okay, that was a very important finding. So for us, this is important, one, to maybe move forward with what we call passive immunization studies. So BNAPs, giving BNAPs instead of drugs. But also, it gives you a good idea of what do we need to achieve with a vaccine. So I'm particularly interested in that part of BNAP research, because we need to understand what are the correlates of protection that a vaccine needs to elicit to be protective. And at the moment, we think it's to generate BNAPs. Okay. So if we look at that at CAPRISA, we've been through this 15-year-long journey where we had a cohort of newly infected women, and we followed them, and we managed to take blood regularly. And then this lady was started on treatment. That was actually 12 years ago. And then we managed to isolate this broadly neutralizing antibody from one of the B cells. So B cells make antibody. T cells help you to protect your body from infections. And we managed to then isolate that B cell. We got help from the US, the Vaccine Research Center, to clone the cell and then mass produce the antibody. And that's where you see it in a vial. And it's now in the clinic in the same population. We're giving it as a subcut injectable every 6 months. So here you see that we call it the trilogy, inspired by Lord of the Rings. But we've got 3 studies here. The phase 1, 012A and 012B have been completed. They just looked at safety of these antibodies and also which antibody would be good to partner it with, and pharmacodynamics. So we looked at how long do they last in the bloodstream. And on the right, you can see that these are quite remarkably long-acting BNAbs. So up to 6 months, potentially, they could have a protective level, which means, you know, that there we are kind of almost in the region of lenacapavir here. But obviously, we need to test that. So we enrolled a lot of people already, and the study is almost fully enrolled. So we're quite excited to see whether these are obviously safe products, but also whether there's potentially a signal of efficacy already. Okay. So in terms of vaccine, we've worked our socks off over the last 10 years. And every conference we go to, we ask that question, how long is a vaccine? And it's always 10 years is the answer. But it's been the answer for the last 20 years. So Mike is laughing. I think he probably knows this. But here you can see our two main studies, the Ohambo trial and the Mosaic Imbokodo trials, that remarkably show almost no difference in the incidence curves. You can see they're almost overlapping, okay? And this is despite us doing really good phase 1, phase 2 studies. So the phase 1 and phase 2 studies, always they say, you know, it's safe, okay, it's safe. And then the phase 2 study help a little bit more with the immunogenicity. So we're showing that we're eliciting strong antibodies against HIV. The problem is they are quite non-specific antibodies, okay? They're non-neutralizing. So they're not as powerful as the BNAbs. So we're not eliciting BNAbs. And that is our problem at the moment. So having said that, we are now completely changing our thinking again about research. And a lot of that is inspired from the COVID research we've done. But here you can see, first of all, on the right, you can see that figure. The red dots are the B cells that are potentially able to produce strong antibodies. So we're trying to stimulate what they call is these naive B cells, and then work out which one can potentially create a BNAb. Okay, it's kind of high precision medicine at the moment. And all the blue ones are not so useful, okay? But if we find a BNAb, and then what they call is we can then stimulate it with another immunogen, and they call it shepherding. So we're priming and we're shepherding. And then we may have another immunogen, like a little vaccine, that can, what we call, polish the response of the immune system and the B cells. Then we can potentially generate BNAbs. It's kind of been shown as a proof of concept, but it's extremely difficult. So at CAPRISA, we're continuing with our BNAb program, and the HVTN are also planning more BNAb. So one of them is, I think it's going to be called Combo AMP with 3 antibodies. We're working on these, what we call germline targeting sequential vaccination strategies to generate broadly neutralizing antibodies. So to do that, we test novel immunogens. Mainly, we would like to use immunogens derived from Africa and test them in Africa rather than, you know, other products, and then design these sequential vaccination trials using mRNA and protein technology that we got so much knowledge about during COVID. And the VTN is working on that, and you heard Glenda Gray talking about the brilliant consortium that's also going to get involved in this. At CAPRISA, we just decided to do an interesting study called the RENEW trial, where we're hoping to, essentially we identified people with HIV who developed BNAbs naturally and those that didn't. And what we're trying to do is give those who didn't an immunogen to generate BNAbs in someone who's already infected. So we're kind of chopping that upper figure in half, and we're starting at the second part. And we're trying to work out, can we, with an immunogen, generate BNAbs within someone who's already infected but doesn't have BNAbs yet. So that's just another concept. And then obviously we need to work on the cure research. We're also using BNAbs in cure research. We think they may add an additional benefit over ART alone. Okay, so one thing we noticed there was that when we start ART, that is when most of the virus that's floating around is going into what we call that sleeping reservoir, okay, of cells. So our strategy in this study is, can we mop up as much virus as possible with an antibody before we start ART? So we actually give high dose antibodies and then start ART a week later. It's just one potential strategy. Right, treatment. Joe, have I got time? Okay, so I've got another 10 minutes. So the treatment cascade, again, we've made remarkable strides, and whoever's here in the room and been involved in the rollout of ART has done a phenomenal job, I have to say. So here you can just see the cascade, and many countries are now reaching 90, 90, 90, but some I hear, even, I think, Joe, your country may have reached 95, 95, 95. Is that right? So for me, it's time, Joe, to revert the cascade and talk about the 5 and the 5 and the 5. We need to be much more granular about working out who are these 5% and why are we not diagnosing them? Why are we not linking them to care? And who are the people that are viremic? Okay. So this is a bit, I've been quite interested in this. This is a nice figure here from Jeff Eaton. He's a modeler, but he's modeling the average age of our HIV, people living with HIV, over the next kind of 20 years. And you can see, we can already see this in our cohort, that essentially it's an aging cohort, okay? And it's rapidly aging. It's aging with us. We were there when it all happened, this AIDS epidemic. So, and overlaid on that, you can see in the dark red, for the women, for example, you can see the viremic people, okay? So obviously in 2010, we didn't have test and treat. So many people weren't on treatment, so you had lots of viremia. And that translates into high population viremia, which means lots of infections, okay? Now, in 2025, we kind of spread almost evenly, but most of the infections and the viremia is still between 30 and 40, okay? But then let's look at 2040. What's happening to the viremia? So potentially we'll have lots more older people who are viremic and also older people who are at risk of viremia and infection. Okay, so it's important to be aware of this dynamic. The other thing that people talk a lot about, I hope you've all heard about this by now, is the cyclical cascade. So it's not a straight 90-90-90 cascade. The big thing is that a lot of people interrupt treatment and then recycle into services and present as new starters. Okay, so this is the Western Cape data from South Africa, and it shows, you can see here that the treatment interrupted group on the bottom there, that's very dark. You can see it's increasing proportionally, and it's now gone beyond 50%. So more than 50% of people who start new ART actually have been on ART before. So my question is, for discussion maybe, Joe, is this population different to the first starters? Personally, I think we have to look at this because, I mean, certainly in terms of resistance and so on, that bigger risk may also be an older cohort, and it may also be more at risk of TB recurrence and so on. So very quickly from our group here, just dolutegravir, there was some doubt whether it works and all the weight gain on all these things. We did an analysis with 200,000 people. Dolutegravir rollout works. So if you're out there in the community, don't go back to efavirenz, okay? We have to roll out this product. And on the right, you can see the inequality. You know, you remember the WHO recommendation. about initially not rolling out dolutegravir to women. You can see that it completely delayed rollout in women, and it still does. We still haven't reached the same level as the men. Okay, so especially with the women, make sure they are all on dolutegravir-based treatment. And it is better in terms of retention of care, and it's also slightly better for viral suppression. So that could be a significant finding. Now, we also looked at second line because everyone is now shifting everyone to the same drug. As an HIV physician interested in resistance, it makes me super duper nervous, okay? We have the same first line and second line in many countries now. Is that correct? This gentleman is nodding. But so we looked at these three regimens. One is obviously what we call the protease inhibitor-based treatment, lopinavir, people know, or Luvia, okay? And we compared it to the dolutegravir on AZT and the dolutegravir on TDF. And you can see that the dolutegravir regimens are superior to the lopinavir regimen in terms of viral suppression. It's another important message. So dolutegravir is probably right for second line. We didn't see a difference between the AZT and the tenofovir dolutegravir treatment. You know, we used to give people AZT 3TC dolutegravir initially, and then people said, oh, maybe we can just give TLD. Okay. So in terms of the drug resistant, this is a graph, I don't want to scare you, but this is NNRTI resistant. This was a paper from 2018. Now the message here is resistant comes exponentially. So it starts very, very low for years. And then once it gets hold of us, gets over 1%, 2%, 4%, 8%, and then it hovers around 15% or so. That's exactly what happened with efavirenz, okay? So although dolutegravir has a higher genetic barrier, we are already seeing in many countries, this is just an example from South Africa, there is dolutegravir resistant. It's not a wonder drug, okay? Policymakers need to understand this. So essentially what we need is good surveillance for this. We need to monitor dolutegravir resistance. And here you can see, so there was a survey done in 2021, and you can see that it was 0.2 for the major resistance samples, and it's gone up to 1.6 already, okay? So when we look at this dynamic of resistance, we've got to be aware of that this may become a problem. All right, quickly, long-acting cabotegravir trials. I think, again, there have been many of these studies. Many of them have been reported. Essentially, the red message is a message, okay, from the initial trials that were done, called FLAIR and others. Therapy with long-acting cabotegravir plus rilpivirine was non-inferior to oral therapy with dolutegravir, abacavir, lamivudine with regard to maintaining viral suppression. So at the time, we were giving abacavir with dolutegravir and lamivudine. At CAPRISA, we're working with London School. We're just doing one of these studies. So I think it's more now about working out which population would benefit most from the long-acting treatment. Okay, so this study is, I think it's quite interesting because it's dealing with people who had either adherence issues or had retention issues. So we're trying to show that the people are being randomized, and we're going to see whether people on long-acting are slightly doing better when they had previous issues with adherence. Now, one thing about long-acting is people think it's the solution for non-adherent people. But what I'm hearing from Europe now, where they've rolled this out, is that it actually means you still need to come on a certain date. Okay, you may have less visits, but you need to have your injection at the right time. So you can't just go on a holiday and then, you know, maybe share your neighbor's pills and come back. And it, at the moment, is still being injected by health professionals. Right, so other treatment options is obviously new long-acting ART regimens, also using lenacapavir, islatravir. Treatment simplification, there's a lot of discussion on that. I don't really have time, I think, to go into that in detail, but there's been lots of trial on dolutegravir, lamivudine, dual therapy. And then we've got advanced delivery systems such as these micropore microneedles that can potentially biodegrade. So those would be tools that can give us long-acting products. And obviously the implant, you know, from many other studies. Just very quickly, we don't just need to innovate in treatment, we also need to innovate in technology. So we're doing a little study here with the University of Washington at CAPRISA, where we're using this urine tenofovir assay in the first 6 months to see whether we can support people through that adherence process. We noted that there's a lot of early attrition in terms of adherence and early viremia. So every visit, people come, they have a urine test, you check for tenofovir. If it's not there, that gives an opportunity to have an adherence discussion. And then from 6 months on, when we do viral loads, we'll use it as a reflex test. So if someone is viremic, we'll do a tenofovir urine test. If that is positive, so you're viremic on a drug, essentially, we'll do a resistance test. So these results, hopefully the 6 months data should be out in the end of the first quarter next year. Yeah, so I'm almost done. The other innovation is differentiated care models, and I think it's really important to focus on this because we're talking about clients, not patients. Is everyone clear about that? We've got clients even in the clinic, we've got clients that are well, many of them. So promoting consistent community ART reduces clinic burden and likely has very similar viral suppression rates. So we've looked at this in this big pharmacy pickup program we have in South Africa, where people essentially can just pick up their own drugs whenever they want from a pharmacy point. And obviously you can then go on a Saturday or a Sunday or whenever it suits you. So, and then also we looked during COVID at 12-month scripts, and we saw there was no difference in terms of viral load outcomes and retention and care outcomes. So I think empowering clients with more modern healthcare solutions is key. We do not need to go to clinics all the time anymore. Okay, I think just conclusions then. So HIV infections in East and Southern Africa are decreasing steadily, and there's a large, rapidly aging population with HIV. HIV prevention toolbox needed for broad population, but with increased focus on the key populations as well. There's exciting, these long-acting PrEP and treatment solutions, but the key is they need to be implemented as soon as possible among those who need them most. Okay, I want to clap for that. And then long-acting PrEP, ART, and these DSD models of care, the new technology innovations, will also then help to strengthen the HIV treatment response and reduce the population viremia. And then obviously a passion of myself, Joe Bina, in vaccine research, and we really want to continue that because it will give us a lot of information about HIV control and eventually a vaccine and elimination of HIV. Thank you.
Thank you very much, Nigel. We took the opportunity, and I'm sure Nigel walked us through the latest innovations in terms of HIV treatment and care in the absence of some of the speakers that we were expecting. It gives us a holistic picture of where we are in terms of the new modalities for therapy. I think in talking about some of the gaps that still exist, there's still a lot of work to be done. Everybody talks about the geospatial mapping, identification of the targeted populations that need us to be addressing these viremic clients, and it needs new studies. One of the latest studies that has been done is using long-acting cabotegravir amongst breastfeeding populations. We know that women are at risk, highest risk of transmission around breastfeeding, and we in Botswana call it butsetse, the confinement period. And therefore, using some of these long-acting injectables will prevent and close a particular gap, an area where we get transmission to baby, transmission to breastfeeding infants. With that, we have 10 minutes of questions, and we can ask questions on anything that Nigel talked to in terms of the innovations for treatment and care on HIV. I believe there shall be some roving mics, and those who are with us virtually are also encouraged to type in their questions, and we shall respond to them. Any questions? Yes. Why don't you use that one?
Thank you. My question is on BNABs for treatment. Have we had cases where there's undetectable resistance so that the viral load is suppressed, but after some time it goes back to the baseline levels? Have we had such instances? Thank you.
We'll have a second question. Yes. And then we'll move across.
Thank you very much for the wonderful presentation. Dr. Nono Blaise from PSI Burundi. Well, my question is this: as in our country, we don't test the resistance in the country, the resistance for drugs, unfortunately. Then for clients who are viral load not suppressed, we moved those clients who are on the first line, even some on second line to DTG-based regimens. And then I am afraid that some of them may be resisting for the other drugs, not DTG. What then can you suggest is we have the challenge of testing resistance? What can you suggest so that we may not come up with a resistance on DTG? Thank you.
Thank you. And then we'll have a third question across the aisle. So we'll remind you.
Merci pour la présentation, cher professeur.
Parlez-vous le français?
Un petit peu.
Un petit peu. We'll need a translator. No, the question is going to be in French. Continue.
Pas de problème.
Merci. Merci, cher professeur, pour votre présentation si brillante. La multirésistance en RDC ne peut plus une question de santé publique, surtout dans le cas de PTM. Aujourd'hui, nous avons les innovations parce que nous avons zéro contamination par rapport au PTM. Alors, quelles sont les innovations que l'Afrique du Sud a apportées dans le cadre de la PTM par rapport à la multirésistance ou à la non-résistance?
Non-résistance. Thank you.
Did you get that? Répétez, s'il vous plaît.
It's about resistance. Not entirely sure what exactly the question is.
We're trying to refine the question. The first one was on BNABs and in terms of treatment. And then the second one was on drug resistance, transitioning patients without HIV drug resistance testing. So we could do those two, and then we'll come to the third one.
Do you want me to take it?
Yeah. Well, I certainly can take the second one. In terms of patients who've been on antiretroviral therapy, who we have been transitioning to the newer drugs such as dolutegravir, I think you still have to have a surveillance program. We want to know within our, different jurisdictions, it's absolutely important for you to know which drugs are still susceptible to therapy. And whilst we did get to believe that DTG did not impart resistance, those of us, like in Botswana, where we started in 2016, are now beginning to see that resistance. And therefore, it is important for every program to have some kind of surveillance to be able to counteract. And that would be my 2 cents worth.
Maybe Joe, can I ask you then, what would be your next step treatment at the moment? Would you go to a PI treatment in anyone where you see dolutegravir resistant, or?
We have just released the new guidelines, and yes, we would go to PI, because the PIs at least have been protected for now from our perspective, and therefore we certainly would.
So maybe just to answer the question, try to answer it. So BNAbs are still very much experimental. Okay, so we're using BNAbs a lot in what we call, analytical treatment interruption studies. So essentially cure studies, where we try to find an alternative to ART to target what we call the latent reservoir, or the sleeping infected cells that wake up when you stop treatment. Maybe the other part of your question is a bit, how robust are these antibodies? How strong are they? We know from ARTs that we have like slightly weaker drugs and more stronger drugs. And it really depends. So there are two kind of criteria. One is breadth of an antibody. So how much of the diversity of viruses does it neutralize? And then the potency of an antibody. So every BNAb is kind of somewhere on that scale. Sometimes you lose a bit. So what we call CD4 binding antibodies, for example, are very broad, but not necessarily very potent. So that's why in these studies, we are now starting to look at combinations. So for example, VRC07LS in the CAPRISA study is a CD4 binding antibody that's long acting, but the CAPRISA 256 antibody is a V2 loop antibody. So it's an envelope focused antibody. So we're trying to combine different properties of different antibodies that have different potency and different breadth. Ideally, as broad as possible should be the coverage, and as potent as possible.
Right.
And just to say, in treatment, that's obviously much more difficult, okay? Because usually in prevention, you've got almost very often you have just a single virus causing an infection. But that's an interesting point. We don't do that routinely. We are doing this in trials because we want to know how sensitive are these BNAbs to the circulating virus. Yes.
There is an urgent question online, and that will be the last one, and we shall answer you because we've got just 2 more minutes. So the question online. No. If not, we'll take one last one on the floor. Thank you. Yes.
Did I understand correctly that CAPRISA are evaluating cabotegravir for treatment? And I'm curious how you're thinking about concerns about NNRTI resistance being so high and the exposure to rilpivirine. And then another clarifying question for Dr. McKenna. Did I understand correctly that you're using cabotegravir in postpartum mums who are HIV negative for prevention, or are you using cabotegravir in neonates who are for postnatal prophylaxis, which I've not heard of, but I'd be very excited if you're exploring that.
Yes, it's a study that we've recently launched, the Tirelotto study on postpartum mothers after delivery, to see and follow them up over time, about a year, to see whether they would transmit. Thank you. 1 minute.
Yeah, so that's a good question about cabotegravir, rilpivirine. I personally am learning a lot about rilpivirine. Again, it doesn't seem to be the strongest drug. And I think the trials will show us. So we obviously, there's a lot of inclusion-exclusion criteria in these studies that are screening out a lot of people with severe resistance, okay? But I think that's really important in terms of the target profile at the end, which population will actually benefit from this. So I think we'll look into that and hopefully we'll have some findings soon. Thanks.
Well, thank you very much. I think that's all we have time for in terms of this session. Thanks to Nigel. Let's give him applause for his presentation. And